Dr. Divatias, he spoke excellent as usual. And even Sugamadex was very good, presentation by Dr. Khade.
There was new agent, Caladibian, something like that, no? That
But
is going to
madam,
come in the
it has,
market
it
recently,
has
which
not
will
come in the,
reverse even
no,
atracurium.
and it has not come
Even
in the market.
succinylcholine local anesthetic as well as the effect of ketamine. That's what he said. Calabidian 2, something.
Huh. But it will take time, madam. So let's not Sugamadex is better for us, and it is really excellent drug, Sugamadex. I like it very much.
But madam, your video just had got hanged for some time.
I
Achha,
know.
I thought now it is okay. We can
Yeah,
hear
now-
you.
yeah.
So usually how many delegates attend usually, madam? Roughly all from the limited to Pimpri Chinchwad or anywhere, like what, how is your experience, previous experience?
Depending on the topic again.
Yes. Topic and area of interest, and sometimes
Nowadays, so many webinars are going on by the state. So most of the time people are then, "Arey, ye to suna hai." Let's see.
okay.
And it depends on how vigorously we circulate the flyer.
Correct.
Hello, Ganesh. Am
Yes,
I
madam.
muted?
Yes, madam.
No. Please unmute me. Like yesterday, there was a new agent which he said that was the atracurium as well as succinylcholine phase 2 block. And ketamine as well as local anesthetic agent. That's what he said like that. So it's going to come into the market in this, I suppose, soon. So which will be a boon for anesthetists. No worry for reversal. Whichever the block of agent, and no worries for reversal and making patient conscious.
मॅडम थोडा तुमचा आवाज ब्रेक होतो ऍक्च्युली थोडा
Break
रेंज प्रॉब्लेम आहे.
हो, एक मिनिट हा, मी दार उघडं ठेवते सो दॅट is that okay now?
Yes, ma'am.
Yeah. Okay. Yeah. Hi. How long we should wait? Since we said 7:15, we can wait for 5 more minutes.
Sure, madam.
It's 7:15. It's said. No, it's still time for 7:15. I think
7:15 onwards, we said like that. Because many a times, even if I say 7, people join by 7:15. That's what I said. Sharp, they will join by 7:15.
Hello, good evening, madam.
Good evening.
Good evening. So,
मॅडम मी ड्राईव्ह करतोय जस्ट एक 5 मिनिटात पोहोचतो वाटल्यास.
sure.
ओके थँक्यू.
Rajesh sir, how is the weather at Nagpur? Is it very cold?
Chilly, cute, and nicely tolerable.
Okay, okay. Everywhere it is, the Pune is still colder and pleasant. Right,
Yeah.
right now, yeah.
Pune is always pleasant. It has always been pleasant.
Pune is still tolerable.
Hello, madam, please unmute yourself.
Rajesh sir, would you like to take the question answer immediately after your lecture, or at the end of the webinar? What you say?
Madam, after my lecture, because I'm going for another lecture in Hotel
Yeah,
Center.
yeah. There must be few questions, as you are very expert in giving lectures.
Not at all expert, just human being like all of you.
Yeah. So I'm proud that you are the first anesthetist in to
Yes,
be
yes,
evaluated
madam.
in national,
We should be really
international.
proud. We
Yeah.
should be really proud. And I'm very proud because he's my batchmate and my very good friend. And he has excellent, he has excelled in the diabetes management. And he has got a ICU intensive care unit and he's managing both the fronts as an anesthesiologist and as a physician also. So it is really a proud moment for all of us.
Yeah, I'm
Thank you so
happy
much,
that
ma'am.
one anesthetist can have so many qualities. Like
In
apart from
Miller's
the
textbook of anesthesiology, when I was PG student at GMC Nagpur,
okay,
I used to read electrolyte imbalance from Miller.
okay.
So Dr. Miller had written a simple, a very good statement that every anesthesiologist is a very good perioperative
Is there some
physician.
kind of sound disturbance? I'm not hearing all the things clear.
Madam, we can hear it properly. No, we can hear it, madam.
Every anesthesiologist is a good perioperative physician.
Physician, yeah. That sentence is there, and it struck my mind since that time itself.
Why not?
Uh,
Why not?
So, but the only thing is that because, and if we see Stalting's textbook of that clinical anesthesiology, if we see all these textbooks, no, we can see that 80% portion, whatever we read, is only medicine.
Okay. Whatever comes on the OT table and the
Yeah.
OT operation theater, we got to manage however it is.
Only. Like thyroid storm is medicine. So before going for anesthesia for thyrotoxicosis, we have to read thyroid storm and its management. So what is, I mean, the complete part is medicine.
Medicine, correct.
And should be well taken care of by all the anesthetists, and they should also start, I mean, doing their own case. I mean, I never called any physician to my hospital.
Rajesh, you know everything, but we don't implement. You have implemented, you have put your dedication into it, and
I
that's
want
what
everybody to implement that. तो अपने को ही physician बनना है. Because मैंने जितने भी physicians को बुलाया ना, I actually MD, whatever people are doing MD medicine, they are doing MD general medicine.
Okay, yeah.
If you see the degree, it is general medicine. That degree is not written like that MD cardiology or MD dermatology. So, secondly, even these people sometimes they miss the heart failure rails also. In my ICU, 2-3 times I called a physician, but he was not able to even diagnose the rails, the basal crepitation, the basal rails, which we find in heart failure patients. Since that time, I stopped calling them.
Good. Good thought provoking to all others, those who are listening.
absolutely.
I'm sorry we are taking your time, but
No, madam, कोई problem नहीं.
नहीं, नहीं, actually, our official time is 7:15.
7:15. Let's wait.
Maybe 2-3 minutes more.
Nice problem.
हा. आणि ऍज युजल लोकांचं खूप रिलक्टन्सी असते पटकन जॉईन करायला.
नाही, आता मेडिकल ऑडियन्सचा प्रॉब्लेम झालाय. आता मेडिकल ऑडियन्स यू डोंट गेट, कुठेच नाहीये, म्हणजे इव्हन कोणत्या मेडिकल ऑडियन्स कमीच झालाय, कारण सगळं युट्यूबवर अवेलेबल आहे, सगळे व्हिडिओज आहे, सगळे इंट्युबेशनचे व्हिडिओज, त्याच्यानंतर सगळं सगळं अवेलेबल आहे, सगळ्या बुजीज मिळतात पाहायला.
At the tip of your finger. Every knowledge is at the tip of your finger. And that
आपल्या वेळेस नव्हतं, पण आता झालंय.
Yes, very true.
now reading the book becomes less nowadays, isn't it?
हा.
And the social media has been is more, which is let's see. Ganesh has to go somewhere, like he's got some medical emergency. He has to take someone to the hospital. So, should we start now?
Hello.
Yeah, should we start now? He has to take his relative to some hospital. He requested to start.
Yeah, we can start, madam.
Hello and good evening to all, my seniors, colleagues, and friends present here. I, Dr. Aditi Elmar, invite you all for this online webinar on diabetes mellitus and anaesthetist perspective, which is organized by Society of Anesthesiologists Pimpri Chinchwad, SAPC, in association with Society of Anesthesiologists Maharashtra State, SAMS. I request our President, SAPC, Dr. Shobha Vadkar Madam, to kindly deliver her welcome note. Over to you, Madam.
Good evening and Happy New Year 2024 to you all. This may be the first webinar of the year this year. It has been such an honor to be the part of this event. On the behalf of Society of Anesthesiologists Pimpri Chinchwad, I would like to extend my heartfelt gratitude to our esteemed guest, Dr. Amit Dixit from Pune and Dr. Rajesh Deshmukh from Nagpur. Dr. Rajesh Deshmukh is the first anesthesiologist in the national and he was invited as the first national and international conferences, and he has got 59 lectures in the conferences. Both of them have very illustrious careers spanning over the period of 15 to 20 years. Thank you both of you for sparing your valuable time in spite of busy schedule. We have been bestowed today with such a national and international personality who served various institutions in the field of anesthesia. They have exceptional anesthetic skills for which they have been awarded, and their words of wisdom will follow in our lives. SAPC is trying to organize online webinars and physical meets in future on various topics with guidance of SAMS. We are arranging COLS and BLS activities to the different hospitals and social groups. My sincere thanks to all the SAPC committee members who strived hard to make this event successful and handling the event throughout. Finally, I would like to thank you all those who are logged in and with us today and helping us to make this webinar a grand success. Now I welcome Dr. Aditi Elmar to give a brief introduction of our speakers. Over to you, Aditi.
Thank you, Madam. A few things before we just start off. I would request everyone not to unmute in between the meeting. Secondly, questions, if any, can be put into the chat box. Also, they will be taken at the end of every session. Also, stay with us till the end so that you can take maximum benefit of the seminar that we have arranged. Thank you so much. Inviting our first speaker, Dr. Rajesh Deshmukh from Nagpur. He is a diabetologist, anesthesiologist, and a podiatrist. He is the director of Jyotirmay Hospital and Diabetes Care Center, Nagpur. He is qualified as an MBBS DA DNB anesthesiology, diploma in diabetology, diploma in lipid management, diploma in cardiology, advanced course in podiatry. He is the vice president, Diabetic Association of India, Nagpur, executive council member of IPA. He is a life member of IPA, a member of SCCM, a member of ISA. Sir has presented papers in Chelaram International Diabetes Summit 2022. He has also presented a case on diabetic foot ulcer at DAI Nagpur in 2021. Today, Sir is going to talk to us about anesthetic management in DKA for emergency surgeries, post-operative management of diabetes mellitus, and gestational diabetes mellitus. Over to you, sir.
Thank you so much, Dr. Aditi, madam. Thank you so much, ISA Pimpri Chinswad and ISA Maharashtra as well for inviting me on this platform to talk in front of my friends. So nice of you. And thank you so much, Vatkar, madam. Thank you so much, Maya, madam. Of course, here I will call her madam, even though she is my batchmate. Thank you so much, all of you. Let us start today's topic. The topic that has been given to me is anesthetic management in DKA for emergency surgery. That is my first agenda. Second one would be, I would be talking on post-operative management of diabetes mellitus and management of gestational diabetes mellitus. Of course, with the view of diabetes as a perspective. So I will start sharing my slides. So coming to the introduction part, the diabetics have increased perioperative morbidity and mortality due to multiple organ involvement. Autonomic nervous system is involved. Before starting any session of DKA, I would like to give a brief idea about diabetes and what it is doing actually before treating DKA. So autonomic nervous system is involved and hyperglycemia leads to impaired wound healing and formation of granulation tissue with poor tensile strength of collagen. There is an impaired humoral host defense mechanism and abnormal complement function. So achieving perioperative euglycemia or normal sugars that will reduce the morbidity and mortality. Surgery causes considerable metabolic stress in non-diabetics, but more so in diabetics. So this is very important word, and wherever I would like to stress, I have written it in different colors. So coming to the diagnosis of diabetes, first of all, so diabetes mellitus is said to be there if fasting sugars are more than 126 milligrams per deciliter and the postprandial sugars or the 2 hours after 75 grams of glucose load, OGTT or whatever, directly postprandial sugars, they are more than 200. And impaired glucose tolerance, IGT, is said to be if the sugars are between 140 to 199, and impaired fasting is said to be if it is between 100 to 125. A very small short note on pathophysiology of type 1 and type 2 that needs to be told over here to understand the complete topic of decay. So type 1 genetic susceptibility is the main factor, environmental trigger because of viruses or toxins, and that will lead to the immunological activation, that is autoimmunity. And this autoimmunity is against the beta cells, and that will lead to progressive beta cell destruction and leading to type 1 diabetes. So coming to the type 2 diabetes, so mainly type 2 diabetes is basically because of impaired insulin secretion or impaired beta cell function. That can be more appropriate word. Peripheral resistance is the second part. So it comprises of three things. One is impaired insulin secretion, one is peripheral resistance, and the third is excess hepatic glucose output. And in case of gestational diabetes, basically there is a sluggish insulin secretion after meals. That is because the baby is there in the womb, the functions of the human body have already increased, and that the hemodilution is there, the blood volume has increased, the weight has increased, and therefore pancreas suffers from excessive load. And therefore there is insulin resistance, and that is also because of certain hormones like HPL, human placental lactogen, prolactin, and cortisol. And expression of IRS1, that is insulin receptor substrate 1, is diminished, which is required for insulin post receptor signaling in pregnancy. And facilitated anabolism is reduced, and accelerated starvation, that is catabolism, is enhanced. So stress of surgery and anesthesia stimulates adrenomedullary axis. We all know about this, and this in turn releases 4 hormones: glucagon, catecholamines, growth hormone, and cortisol. And all of them, they collectively augment the fuel production from the fat. So instead of using the glucose as a substrate, they are using fat as a substrate. And that makes all the difference, leading to fatty acid breakdown and formation of alpha butyric acid. So, or the glycerol and other acetoacetic acids. A normal person will release extra insulin from beta cells to utilize this extra fuel, which is not possible in a diabetic or a badly managed diabetes. Require supplementation of extra insulin in perioperative period. So why there is worsening of diabetes during surgery and anesthesia? If you see this slide, this has been taken from Sheshia's textbook of diabetology. This is my favorite slide, why this happens, and I always refer this slide in my anesthesia cases at my hospital. So whenever there is a surgery, the trauma ought to be there, hemorrhage ought to be there, and if at all the patient has super added infection before taking the patient to the OT, then the things will worsen. So all these 3 things, they will lead to stress on the body. This will lead to increased sympathetic activity. And at the same time, all these 4 hormones that I discussed right now, they would be increased. And they are also called as counter-regulatory hormones. So all of them, they will lead to insulin secretion would be inhibited. These counter-regulatory hormones, they will lead to insulin resistance. And all these things, they will lead to glycogenolysis, gluconeogenesis, proteolysis, lipolysis, and ketogenesis. So all these things ultimately are leading to decay. Now, these are the 10 commandments I always followed in my 25 years of anesthesia practice. I started it from 1999. So almost 25 years are over. So 10 commandments anesthesiologists should remember. The first one is that a patient with advanced diabetes will always have coronary artery disease. We have to think over that. He may be having cerebrovascular disease. He may be having progressive renal disease. He is always having hypertension, always suspect hypertension if the patient is diabetes, with high sugars, with high HbA1c, with fructosamine levels, even if they are out of range. Autonomic neuropathy is something that anesthesiologists should always remember. These people are also having peripheral neuropathy, and therefore in bracket I have written that lesser doses of regional anesthetics would be required. These people are always having dehydration because diabetes is a state of dehydration. They are always having electrolyte imbalance. If you see a patient of diabetes who is a chronic diabetes, you will always find hyponatremia in that patient. So I have written that particular point. Infections are always there, and UTI is the most common. Why? I will come later on. I will tell you later on. Gastroparesis is always there. That is also called as diabetic gastropathy with delayed gastric emptying. Now, this is something very important for anesthesiology point of view. Gastroparesis with delayed gastric emptying. Therefore, there are more chances of aspiration during intubation. So stiff joints because of osteoarthropathy. Suspect difficult intubation due to stiff atlantoaxial joint. Incidence of silent, that is painless heart attack, is more because of autonomic neuropathy. These people, they do not get pain if they get a heart attack, and that is something very dangerous. Incidents that they may be dying at night in sleep. Now, we should also understand which drugs they cause hyperglycemia and which drugs they cause hypoglycemia. So the first drug that is causing hyperglycemia is the glucocorticoid, thiazide diuretics, chlorthalidone, beta blockers, antipsychotics, and certain anesthetic agents we all know about them, like halothane and ketamine, are also known to cause hyperglycemia. And antiretroviral medication, of course, that is why the history of HIV, and that's why we are getting the test done before the surgery. Coming to the drugs causing hypoglycemia, now very few people, we are very much fond of using tramadol IV. It is the anesthetic of choice or opiate of choice during analgesia, extra analgesia that we require during our GA cases or regional anesthesia cases. So tramadol IV or oral is the agent which leads to severe hypoglycemia. MAO inhibitors, they lead to hypoglycemia, haloperidol, then quinidine or pentamidine, then trimethoprim plus sulfamethoxazole, then beta block. And this last point, this is very important. Beta blockers, if we are using intraoperatively, IV, will mask the symptoms of hypoglycemia. And carvedilol, in these situations, if at all we want to use the beta blocker, it should be carvedilol. That is the preferred one. At any cost, the symptoms of hypoglycemia, they should not be masked. And these symptoms are tremors, slurred speech. Of course, the anesthetist patient will not be having slurred speech, but if he's under regional anesthesia and if we are talking with him, he may be able to speak out, and that time itself we have to notify whether he is speaking clearly or there is a slurred speech. And this slurred speech is a most important symptom of hypoglycemia. Now, coming to the management of DKA before taking the patient to the OT. So we cannot take the patient directly to the OT unless we manage the dehydration created by DKA, unless we manage the cardiac parameters, the tachycardia that he's having. So we have to hydrate the patient, and that is why this slide in front of you is showing IV fluids, and I have clearly written give 2 to 3 liters of 0.9% normal saline over 1 to 3 hours. Step down later on to 0.45% normal saline at 250 to 500 ml per hour. When blood glucose levels are more than 250 milligrams or equal to 250 milligrams per deciliter, add 5% glucose to 0.45% normal saline at 150 to 250 ml per hour. Now coming to the insulin drip. First of all, we have to give a bolus because all these patients, they will come to us with 500, 600, 700 sugars. And their HbA1c would be also around 11, 12 because these are the patients who are the defaulters of the diabetes treatment. They have skipped lot many insulin dosages, or they may be having that times hyperglycemia or severe hyperglycemia or ketosis in DKA because of skipping not only the insulin but also having infections and septicemia. So insulin drip is needed over here, and therefore give short-acting regular insulin, that is Actrapid. All of us know not many insulins are there, and the dose would be 0.1 units per kg IV bolus. So the first thing that we have to do is a bolus. That means if the patient is having weight of 50 kgs, so 0.1 into 50 is 5 units. That means 5 units we have to give bolus. After that, again, we have to start 0.1 unit per kg per hour in the form of IV infusion. Here, even insulin pump can be used. And later on, 0.05 to 0.1 units per kg per hour IV infusion. So 2 to 4 hours overlap in insulin infusion and long-acting insulin injection should be there. Now coming to potassium levels, if the potassium is less than 3.3 milliequivalents per liter, we have to hold the insulin infusion because what insulin is trying to put this potassium into the cells along with the glucose. Glucose is a substrate that is needed by the body for our body function. Normally, our brain requires 50 grams of glucose per 8 hours. So in 24 hours, our brain would be requiring around 150 grams of glucose. To put this glucose into various cells of our body, that work is being done by insulin. But at the same time, insulin, when it is putting glucose inside the cells, in our tissues and getting function done from all our organs, at the same time, it is also putting potassium. And that is why if the potassium level is less than 3.3, we have to hold the insulin infusion. So if it is between 3.3 to 5.2, give 20 to 30 milliequivalents per hour in each liter of IV fluid to keep potassium between 4 to 5 milliequivalents per liter. But if it is more than 5.2, do not give potassium. Now coming to the anesthetic management for emergency surgery in the case of DKA. So DKA actually, now this parameter and this slide is coming from British Journal of Anesthesiology. I have recently, I had gone through that, and DKA comes in ASA 3E category. In ASA 3E category, it comes for surgery, and blood glucose levels are to be maintained between 140 to 180. Now, this is the funda of ICU management also. So whether you are in OT, whether the patient is in OT or ICU, the blood glucose levels of the patient in DK are to be maintained between 140 to 180 milligrams per deciliter during intraoperative period. Above 180 milligrams per deciliter, whenever there is a hyperglycemia. So that is the definition of hyperglycemia if it is above 180 milligrams per deciliter. And if it is below 70, there is hypoglycemia. So DKA may present in surgical patients, in non-surgical patients who are skipping insulin. And whenever DKA is there, the patient will complain of abdominal pain, and the scenario is just like acute abdomen. And many a times these patients undergo unnecessary laparotomies because of this type of pain. Another thing that anesthetist is supposed to see is euglycemic decay. This euglycemic decay, it is absolutely different from the routine decay in the sense that in the routine decay or a basic decay, not only there is hyperglycemia, there is ketosis and there is dehydration. It's a triad of three things. And acidosis, of course. But in euglycemic decay, only two parameters are there. There is ketosis, but there is no hyperglycemia. There is acidosis, but there is no hyperglycemia. So that means these patients, they come with normal but with decay, that is euglycemic decay. And this is even dangerous situation, and this is occurring because of a new inhibitor that is called as SGLT2 inhibitors. The names are empagliflozin, dapagliflozin, canagliflozin. These are all we are using because these drugs are very good. All these SGLT2 inhibitors are very good. They are kidney safe. They can be given in even if eGFR is less than 30 ml per kg per 1.72 meters square of the body surface area. So all the physicians, all the diabetologists, now I will use the word as diabetologist. I do not want to use the word as physician. So if any patient is on ramipril, now this is another point that we should remember. If any patient is on ramipril and is undergoing any emergency major surgery involving blood loss, that is hypovolemia, ramipril will compound or complicate the low output state created by blood loss or intraoperative hypotension. This is another thing that we should remember. Now, there are two terminologies while making the insulin infusion, that is variable rate insulin infusion, VRII, variable rate insulin infusion, or FRII, that is fixed rate insulin infusion. And this is used pre and intraoperatively to control the blood sugars and to maintain them between 140 to 180 milligrams per deciliter. We have to avoid the starvation of all these patients, and they are to be taken as an emergency case just to stabilize. We can stabilize them in an hour and then we can take them inside the OT. They are to be taken as high risk cases with informed consent. Coming to the most mandatory investigations before taking the patient to OT. We have to see the capillary blood glucose every 15 minutes on operation table. I usually do it with the help of AccuCheck Instant S glucometer, which is Bluetooth enabled or compatible. And that is the glucometer which has got the gold standard award in the World Glucometer show rather. Then we have to go for serum ketones. And serum ketones more than 3 millimoles per liter, that signifies DKI. This is very important point. We have to go for KFT because all these patients are suffering from diabetic nephropathy. We have to go for serum electrolytes because most of them are chronic diabetics and they have got chronic hyponatremia or as well sometimes hypokalemia as well. They may also be having hyperkalemia because they are constantly under antihypertensives, which are using, and physicians are using chlorthalidone or hydrochlorothiazide, which are leading to hyperuricemia and hyperkalemia. So serum electrolytes are must. They are to be, we should also have ECG because all these patients, they are the patients of diabetic cardiomyopathy. We should always have CBC, which will highlight us about their anemia status, or it will let us know about other things like platelet counts and all. We have to have ABG to understand the acidotic state of that particular patient. And we should also have serum lactates because lactic acidosis is prevalent. Other investigations as per the clinical picture at that particular time. Now, who is eligible to start this infusion, that is variable rate insulin infusion? This can be started by infusion pump in the ICU, or it can also have a drip impact that would be coming in the next slide. So who to whom we should start this particular VRIII? Type 1 diabetes mellitus who has missed one meal and undergoing surgery. Now he is missing one meal means he is starvated already. And starvation will precipitate the lactic acidosis and so DKA. And at the same time, he has also skipped the insulin dosages. So this is the person who is eligible. Type 1 diabetes mellitus who is undergoing surgery without taking recommended insulin dosages. The third factor is type 2 diabetes mellitus with capillary blood glucose more than 216 milligram per deciliter or 12 millimoles per liter. And here, my calculation is simple. 1 millimole per liter of glucose is equivalent to 18 milligrams per deciliter, according to Indian standards. Patients with HbA1c more than 8.5, they are all eligible. These are all eligible candidates. This is the list. Half-life of, now this is very important point, that half-life of soluble insulin is only 5 minutes. So if you stop variable rate insulin infusion for 15 to 30 minutes for any reason, type 1 diabetes patients will rapidly deteriorate to have decay. Now this decay can be there before taking the patient to OT or even while shifting a extubated patient from OT to ICU. It can happen at any time, and that is why we have to continue the drip of variable insulin infusion to type 1 diabetics. So this variable insulin infusion is continued till ketosis disappears. Patient starts eating and drinking and resumes his subcutaneous dosages. 0.9% of normal saline with pre-mixed potassium chloride should remain ready to tackle hypokalemia and shift these patients to ICU only from OT and not to recovery wards. Now, this is the typical preparation of the insulin infusion. We have to take 50 units of regular insulin dissolved in 50 ml of normal saline in a 50 ml disposable syringe. How is the mode of administration? This slide is taken from this journal. This journal is International Journal of Diabetes in Developing Countries, and this journal is endorsed by Research Society for Study of Diabetes in India. So after doing this 50, 50, and 50, mode of administration would be intravenous infusion with an electronic or an infusion pump. The choice of IV insulin is a short-acting regular human insulin. The primary target is, I again said in my last slides, that the primary target is to maintain the blood sugars between 140 to 180 milligrams per deciliter. And the control methodology is that the blood glucose to be controlled gradually in case of severe hyperglycemia by titrating the dose of intravenous insulin. Now coming to the prerequisites, initially 15 to 20 ml of solution should be flushed through plastic tubing to saturate the insulin binding sites in the tubing. Coming to the targets, dose should be adjusted as per the levels of blood glucose, and monitoring is either by CBG, that is capillary blood glucose by the good quality glucometer, or from the venous site or the central line every 1 hour until blood glucose stability has been demonstrated. Monitor serum potassium levels and check regularly for blockages, disconnection, infusion pump malfunctioning. Coming to the emergency surgery. This slide is also taken from the same journal that I showed right now. And this has got a drip calculation for those settings which do not have any infusion pump. The formula for this particular drip calculation is that blood glucose upon 100 is equal to units per hour. And Dr. Sheshiha, whose book I read during my diploma in diabetology of 2 years, clearly mentions that sugar 400, 4 units, sugar 500, 5 units. That means if you see here, blood glucose upon 100 is equal to units per hour. So if the blood glucose is 500, 500 upon 100 is equal to 5 units per hour. It is simple for the anesthetist. If it is 300, give 3 units. If it is 400 sugar, give 4 units. If it is 600, give 6 units. And that is per hour. Now coming to another point, we have to put 25 units of regular insulin, that is ectrapid insulin, in 500 ml of normal saline. This will make the concentration as 0.05 units per ml by regular macro drip set. Now 0.05 into 20 ml is equal to 1 unit of insulin. And now 1 ml is equivalent to 15 macro drops. The formula for working out flow rate is volume into drop factor upon time. That is 20 into 15 upon 60. So that comes out to be 5 macro drops per unit. I request every anesthetist to just take a snapshot of this particular slide and keep it in the pocket, so that, because this is slightly difficult, if you keep the snapshot of this, it is very easy to use. So 1 macro drop is equivalent to 4 micro drops. And this is very, macro to macro is 1 macro is equivalent to 4 micro. So 1 unit of insulin would be either 5 macro drops per minute or 20 micro drops per minute. After doing all this said and after preparation of this drip, we have to, now we are giving this drip to the DKA patient in the OT, outside the OT, before the OT, and even in ICU for 24 hours. So in the 24 hours, whatever is the TDD. Now what is TDD? TDD is the total daily dose of insulin given IV. So if it is 50 units, then we have to calculate it that we have given 50 units in the 24 hours. And when we are shifting that patient from IV insulin to subcutaneous insulin, that time out of this 50 units, we have to give 80%. If it is 100 units, it would be 80 units. If it is 50 units, it would be around, I think, 40 units. So 80% we have to give in subcutaneous mode in the next second, third, and fourth days. Out of this 80%, 50% of insulin always, whenever it is being given by subcutaneous doses, 50% is given as basal insulin, that is Lantus, Glargine, Degludec, Toujeo, which is actually 300 units per ml. So these are the names of the basal insulins, and 50% in the form of boluses. Boluses may be divided into 2 categories: one regular boluses, one analog boluses. Regular bolus is the Actrapid, that is regular insulin. Analog is Aspart, Glulisine, and Lispro. So this is all about subcutaneous dosages. No surgery is to be done if the patient is in immediate diabetic ketoacidosis. However, this sentence is very important. If the benefit outweighs the risk, case can be taken up with due risk and informed consent. Intraoperative and postoperative management of DKA during surgery. This slide is taken from British Journal of Anesthesiology. Invasive BP monitoring is preferred in this particular case. Instead of a NIBP, we have to get an arterial BP, because many of them are prone to develop acute kidney injury due to pre-existing diabetic nephropathy and because of micro and macrovascular complications of diabetes. Because in diabetes, in the kidney, there is a mesangium and there is a proliferation of mesangium, which leads to obstruction of kidney, and that also leads to fibrosis of kidney, and that condition is called as intraglomerular hypertension. So these patients, they'll end up in AKI. So anesthetic technique should promote cardiovascular stability, and we have to use our induction agents, which will definitely promote a cardiovascular stability. At present, we have 2 induction agents which have got very good cardiovascular stability, and everybody is using them in the form of propofol and thiopentone. Thiopentone has a very good cardiac stability. Avoid opiates. This point is very important. Avoid opiates in regional or general anesthesia, as they lead to post-operative nausea and vomiting, leading to further electrolyte imbalance. And in DKA, we do not want further electrolyte imbalance. Now, this is very important clause that is in brown color. Many patients are on newer insulins like Rhizodic. Rhizodic is the insulin which has got a half-life of 45 hours. That is the combination of Degludec plus Aspart in 70 and 30 combination. This is ultra-long-acting insulin with a half-life of 42 hours. Such patients may need little amount of glucose insulin drip in the OT or may not need it at all. It is not necessary that at one particular time before taking the patient to OT, sugar is 400 and I will need 4 units IV bolus. It is not like that. So I always start, whatever are the dosages given in the books, I always start 1 unit less. Because once the bullet is out, it will not come back. Many patients nowadays, they are on GLP-1 agonists like semaglutide, Rybelsus. Right now, I am going to Center Point Hotel for the same lecture, that is Rybelsus in India, and they are on SGL2 inhibitors like empagliflozin and dapagliflozin. Now, these 2 agents, that is GLP-1 analogs and EMPA and DAPA, they augment DKA. These drugs are to be stopped before taking the patient to the OT. And this has to be clearly told out to the surgeon wherever we are going, that, sir, please stop these two agents if the patient is already there, at least for elective cases. So even DPP-4 inhibitors are stopped and patient is managed only by glucose, insulin, potassium drip. But I use different. Glucose, insulin I use different, and potassium I use different. Of course, while tackling all these cases, we have to remember our God. Now there is another drug that the anesthetist should be alert of, is called as hydroxychloroquine. This hydroxychloroquine is a drug which increases the insulin concentration in the blood, and it prevents the insulin metabolism so that the lifespan of insulin increases. So insulin binds, here in this slide is a green color. It binds to its receptor on the cell membrane. There is internalization of the receptor insulin complex. See, this is now internalization of the receptor complex. And the red colored molecule is that of hydroxychloroquine. This is going inside. This is going inside. This is also going inside. Now, what hydroxychloroquine is doing, it raises the intracellular pH and results in activation of all these insulin degradation enzymes. So now this insulin molecule, which is green colored and which is coming out of the cell, is free to join the receptor again. That means insulin's action has increased. In these patients who have taken the tablet of hydroxychloroquine 300 to 400 milligrams, which is the recommended dose in type 2 diabetes mellitus, and most of the diabetologists are using this drug nowadays to reduce the insulin dosages. If the patient has taken this particular drug, we have to reduce our insulin dosages inside the OT while tackling the case of DKA. This insulin is going again, and now this is again going an action. So now coming to the next slide. Hydroxychloroquine and anesthesia. This slide is being continued. So we should wait and watch before suddenly starting glucose insulin drip if the patient has taken tablet hydroxychloroquine that I told 6 to 10 hours before the operation. That history is important. Intraoperative hyperglycemia, if it is about 250 to 275, you can start glucose insulin drip with cautious monitoring if the patient has taken this tablet. In post-operative period, the levels of glucagon, all the counter-regulatory hormones and cortisol will return to normal, avoiding the need for glucose insulin drip. So just keep the drip in your hands and see the blood sugars and act accordingly. Coming to the perioperative management in major surgery, objective is to avoid the hyperglycemia, hypoglycemia, ketosis, and we have to ensure that adequate fluid replacement and electrolyte balance should be there. Glycemic control. Now, this is the post-op management that I'm coming. Glycemic control is aimed to achieve fasting plasma glucose of 100 to 120 milligrams per deciliter and postprandial glucose of around 140 to 200. In type 1 diabetics, now this is for the for routine cases apart from DK. The portion of DK is now over. This is for routine cases for major surgeries. That if the patient is type 1 diabetic and if he has got a good metabolic control, admit a day before surgery, and if he has got a bad control, admit 3 days prior to surgery to achieve euglycemia. In case of type 2 diabetes, these patients, they are on oral hypoglycemic agents, which are stopped on the day of surgery. If they have got a poor control, these patients are also, they need to be admitted 2 to 3 days prior to achieve the euglycemia. Coming to the subcutaneous insulin therapy on admission, 140 to 180 milligram per deciliter. We have to give 5 units before taking the patient to surgery inside the OT. Subcutaneously. That means every patient will not need the drip. Some patients can be taken to OT, major surgeries, even by giving subcutaneous dosages. If the sugar is between 180 to 220 milligrams per deciliter, give 6 units subcutaneous. If it is between, and this is also for emergency surgery. This timetable and this guidelines can also be used for emergency surgeries who are not in the diabetic ketoacidotic state. So if the sugar is between 220 to 260, 8 units can be given SC, 260 to 300, 10 units. If the sugars are more than 300, 15 units of regular insulin before breakfast, before lunch, and before dinner. But if there is still failure to achieve the target, surgery can be postponed for a while or the next day. Sugar can be controlled by the pre-mixed insulin of even 30-70 or 50-50 before breakfast and before dinner. Basal plus therapy, basal bolus therapies can also be tried. And basal insulin is always to be given preferably at 8 to 10 p.m. Basal insulins are always aimed at controlling the fasting sugars, and prandial insulins will control the prandial sugars. And this is all the major guidelines for both emergency cases as well as elective cases. On the day of surgery, what is to be done? Diabetics should be taken up as the first case in morning OT list. Normally, 0.3 units of insulin is required to metabolize 1 gram of glucose. Point is important. So if the fasting sugars are less than 120, no insulin. If they are between 120 to 160, 4 to 5 units, here the dosages they are coming down. The same dosages can be used for gestational diabetes mellitus patients. That was my third agenda. If the FPG is more than 300, again 10 to 15 units in normal saline can be given with the same drip calculation that I told in my last slides. Surgery is delayed till euglycemia, and all these infusions are given at 30 drops per minute or 100 ml per hour. Same regimen works for post-operative period. Coming to the intravenous fluid to all these types of patients, DNS can be used in decay because we also need a substrate that goes inside the cells and does body functions, glucose. We need glucose for our metabolism purpose. So DNS-NS is used if the patient has normal BP. If the patient has hypertension, 0.45% normal saline is used or 5% dextrose saline is used with cautious use of insulin as well. Brain requires 50 grams of glucose per 8 hours. I already told in my last slide. To meet this demand of 150 grams of glucose in 24 hours, what is needed is 1000 ml of 5% dextrose saline is required every 8 hours. In hypertension and CCF, that is congestive cardiac failure, it is safe to use 0.45% normal saline with central venous pressure monitoring. If situation warrants fluid restriction, instead of 5% dextrose saline or 10% dextrose saline, they can also be used because it has got less content of water. Insulin dose in infusion will have to be doubled. Infusion of isolate M, that is the maintenance fluid, is alternated with DNS or 5% dextrose to avoid insulin-induced hypokalemia. Isolate M has enough potassium of around 35 milliequivalents per liter, and if we are using isolate M, we do not require a potassium chloride separately. A few hours after surgery, insulin requirement is always reduced, that I have already told in my last slides, because all the counter-regulatory hormones are coming down to the baseline. So this is potassium monitoring, and that I already told in my last slide. Now, when potassium infusions, when should they be started? They should be started when potassium is less than 3.3 milliequivalents per liter. But if the ECG changes of hypokalemia is evident, T-wave depression, sagging of ST segment, U-on-T phenomenon. Now, in this particular slide, if you see the ECG, you can see the U-on-T phenomenon as well. In these cases only, we have to cautiously start or stop the potassium infusions. So if it is less than please give me some time. So this ECG is to be understood by every anesthetist, and depending on that, if the serum potassium is less than 3.3, we have to start, and if it is more than 5.5, we have to stop. So which potassium infusions are to be used in DKA? Potassium phosphate, 1 ml contains 4.4 milliequivalents, 5 ml contains 20 milliequivalents, that is the neon spot phos. Potassium chloride, that is spot Cl by neon. The strengths are given over here, and potassium chloride, which is famous in the form of Tesol, age-old drug. So potassium levels are to be monitored every 2 hours. Coming for the minor surgeries, on the day of surgery, stop OHA and insulin. After surgery, OHA and insulin is started at half the normal dose. From second post-operative day, start OHA and insulin at full dosage. Now coming to the GDM part of this particular talk. For GDM, the protocol is same as that of type 2 diabetes regarding insulin therapy, hospital admission protocol before surgery. And this is my last slide. So if all these protocols are followed properly, the situation and the scenario would be good. Otherwise, it would be bad and ugly. Thank you so much for your patient listening.
Thank you, sir, for such a crisp talk and about such a vast topic. The subject was very well covered. So we have few questions in the chat box. How do you manage insulin pump? And how do you manage patient on insulin pump?
Madam, I have given that 50 ml of normal saline, 50 units of extrapid insulin in an insulin pump that is to be put. Then we have to actually waste some 10 to 15 ml to actually feed the tubing. And then we have to start that insulin in DK with the unit rate. Also, I had written that bolus should be given as 0.1 units per kg, and then later on 0.1 unit per kg. That is the infusion that is to be given for 3 to 4 hours, and always looking for the CBG, that is capillary blood glucose, that was actually showed in fourth or fifth slide.
So this, how frequently should you do this blood glucose intraoperatively, whether on variable rate infusion or on fixed rate?
Whether infusion is going on, whether for some time anesthetist has stopped the infusion intraoperatively, abdomen is open, surgeon is doing the surgery, the viscera is out, whatever is the condition on that particular side of the curtain, on our side, we have to see every 10 to 15 minutes.
Okay. Sir, about SGLT2 inhibitors also, they should be stopped, as you said, but they should be stopped 2 to 3 days prior to surgery.
SGLT2 inhibitors, sometimes the patient already has taken the dose and is coming for perforation peritonitis at 2 a.m. in the morning.
Right. So in emergencies, we have to take the patient in spite
we
of.
We have to ask the history, we have to see the medications, and these patients of SGLT2 inhibitors, they can have euglycemic decay. And that is why history of SGLT2 inhibitors and GLP-1 analogs. Now, even GLP, see, the patient of DKA will pose as acute abdomen. Okay. Now, acute abdomen, we always need an emergency ultrasound, because these patients of GLP-1 analogs and DPP-4 inhibitors, they may have pancreatitis. And that is why these two drugs are also contraindicated apart from pancreatitis in gallstones. They augment the gallstone formation, and they stop the emptying of gallbladder. So because of these conditions also, there can be abdominal pain. Okay. Surgeon does not know anything ABCD about this.
Right. So we need to stop it in these cases.
Yeah, that is why the study of these drugs is very much important for anesthesiologists. Our science is very vast. Even MD medicines don't read this much.
Right. So also effects of anesthesia on these glucose levels, like you said, volatile anesthetist like halothane would increase the sugar levels. So
very mild. Ketamine increases profoundly. Halothane leads to mild hyperglycemia. If the patient is coming to OT with 200, with halothane it will go to 250, 270, 280.
Right. So, sir, in cases sometimes we say steroids also increase the glucose load.
Yeah,
it's an adrenaline, but there are sometimes when we need to use, like in local anesthetics, we are giving some peripheral nerve blocks.
Correct.
We can use adrenaline along with the local anesthetic.
You can use adrenaline. Here, sugar does not matter because you have got insulin infusion in your hand. You have got insulin drip in your hand. You can titrate the sugar levels. It is in your hand. But what about cardiomyopathy? If there is a diabetic cardiomyopathy, adrenaline will stop the heart.
Right.
So we should be very conscious, and that is why I say that HbA1c levels are very important. If the what ADA says, what American Diabetes Association says, what does RSSDI say, what does EASD say, these people say that if it is more than 10, the micro and macrovascular complications of diabetes have already occurred. If the fasting sugar level of that patient in any time of his history is more than 140 milligrams, fasting sugar is more than 140, 75% of beta cell mass is dead. Okay. So if the 75% of beta cell mass is dead, that means he is almost becoming dependent on insulin.
Right. So similarly, one question was asked, can we use dexamethasone as an antiemetic or an anti-edema?
It has to be used.
Uncontrolled diabetic mellitus.
Hydrocortisone can be used. See, the dexamethasone, hydrocortisone, and glucagon. These are the treatment of hypoglycemia on table.
Yeah.
So dexamethasone 4 to 8 milligrams IV you can shoot if you find that the patient is hypoglycemic, but better than that is hydrocortisone. That is efcorlin.
Okay.
Or Cortez. So if you are giving 100 milligram bolus, you can see the sugar levels are coming up, because if the sugar levels are below 70, the patient will not come out of anesthesia after giving reversal.
The question was actually because if the patient is uncontrolled diabetes mellitus and we have to use a dexamethasone as an antiemetic, like a last resort.
Yes,
so, or an anti-edema after.
The maximum thing it will do is it will raise the blood sugar levels, but you can take the blood sugar levels down by the infusion pump.
Okay. So one more patient, person is asked, tight glycemic control. Your take upon tight glycemic control.
Tight glycemic control word is to be used only for OPD patients. In ICU, OT, the fixed target for euglycemia is 140 to 180.
180. Right.
If it goes below 110, it is not recommended according to the standards of care of American Diabetes Association 2023 guidelines. It, at any cost, it should not go below 110. Now, tight glycemic control is also related to a terminology which is called as time in range. TIR, many anesthetists do not know. This is basically a word of diabetologists. TIR is a range, that is the range of 70 to 180. So this is the range of TIR and this is the range of 140 to 180. So tight glycemic control is aimed at making HbA1c less than 7, or the target HbA1c should be 7. That is called as tight glycemic control. For that purpose, many OHA plus insulins are used, or sometimes basal bolus or basal plus therapies of insulin are used. That is tight glycemic control. So we have to do nothing with that tight glycemic control for a case of DKA or in operation theatre.
Okay. So they've also asked, do we have to use short-acting actrapid of Lantus insulin?
Actrapid and Lantus are different things. Okay. Lantus is a glargine insulin which has got a half-life of 10 to 12 hours. And glargine insulin comes under the category of basal insulin. Actrapid insulin comes under the category of regular insulin. Right. Basal insulins are doing work of pancreas. Insulin secretion is in pulsatile form like ECG. And there is also a baseline insulin secretion by the pancreas, by the beta cells. So baseline insulin secretion is taken care by basal, and pulsatile insulin secretion is taken care by actrapids or analog insulins.
Sir, we have another question. Euglycemic ketosis. What is the ASA grading for this?
It is the ASA grading for this is grade 3B or 4 sometimes, because they are even more dangerous. They do not have hyperglycemia, and that is very confusing. But they have ketosis. So the whole management is just like that of DKA. They need insulin, and all these three categories. There is one more category I did not discuss today because my friend has to talk on this topic. That is HHS, hyperosmolar hyperglycemic coma. That is syndrome, HHS.
Right. How much blood sugars will increase with 100 mg of hydrocortisone and 8 mg of dexamethasone?
Around 150 to 200 milligrams per deciliter. So if the sugars are, see, whenever there is a hypoglycemia for an anesthetist or for our patients is even more dangerous than DKA. Right. Because hypoglycemia leads to severe cardiac arrhythmias and heart block.
Yeah, sir.
Or cardiac asystole. And that is why, and secondly, our patients are anesthetized. They are not able to tell us about their symptoms. The only one symptom in a regional anesthesia can be slurred speech. Right. They do not have shivering because they are all covered. They do not have other symptoms like another thing is tachycardia. Tachycardia is another sign that we can see. Severe tachycardia. But they don't have sweating because we have given them glycopyrrolate. So how they will have sweating?
So when in doubt about all hydrocortisone, any steroid which can increase the blood sugar, you can use it.
Yes,
to avoid the hypoglycemia.
The first thing to increase the blood sugar is 25% dextrose. The first thing, if it is not working, then IV bolus hydrocortisone 100 mg should be given. Wait for another 10-15 minutes.
Right.
Sugars will come up. If they are not coming, give another bolus of 100 milligram hydrocortisone.
Right. So one last question: isn't tight control required in GDM?
In GDM, the scenario of HbA1c control is different than a normal type 2 diabetes. In GDM, tight control is required to keep her HbA1c below 6.5, to keep her fasting sugar between 90 to 95, and to keep her postprandial sugar always below 130.
So, sir, do the guidelines for DKA, like the investigation, the blood glucose levels that we say, do they change for a parturient and for a normal individual?
Yes, they change.
So
The
they lower
normal
down
level of
normal.
now for this is a very good question, and for this purpose we need to know the parameters. Like a patient of the GDM, her HbA1c levels are said to be normal levels and abnormal levels are different. Now, what is diabetes? What are the normal levels of HbA1c for a normal individual? They are between up to 5.7 is called, from 5.7 to 6.4 is pre-diabetes. Below 5.7, it is normal HbA1c according to ADA. From 5.7 to 6.4 pre-diabetes, and 6.5 is the point where diabetes is diagnosed. Okay. For this patient, the normal level of HbA1c is below 5.4 for GDM patient. Yeah, for the parturient. So these guidelines are changing in GDM, but not much difference, because ultimately we see, secondly, the HbA1c levels in gestational diabetes mellitus, they vary. And that is why many a times, instead of HbA1c, the parturient or a GDM has to undergo serum fructosamine levels.
Okay.
Because why? Because HbA1c is dependent on red cell life. The red cell life or the erythrocyte life is 120 days. And in GDM, the 120 days life, actual lifespan of RBC comes down to 90 days.
Okay.
And that is why HbA1c is not a reliable parameter in GDMs.
Okay. Instead fructose, serum fructose.
Serum fructosamine in that case, because there are many conditions which will give which will influence HbA1c. One is hemolytic anemia, one is hemoglobinopathy, one is iron deficiency anemia. These things, they will change the levels of HbA1c, and another fourth parameter is pregnancy. So in these four diseases, serum fructosamine levels can be taken up after sugars instead of HbA1c.
Okay. Usually, an uncontrolled diabetes patient came for emergency debridement surgery. For such patients, 1 day sugar control, what is the acceptable range?
140 to 180, not more than 200. You can give anesthesia. But if the patient has got in any time history, HbA1c of more than 10, always keep all cardiac drugs ready. Okay. Do not infuse, see the hydration status and give, because these patients are dehydrated. But if we, even if they are in hypovolemia during the surgery, that hypovolemia can go later on after intubation. We can keep them intubated for some time, stabilize, and then extubate. Acceptable range for giving anesthesia would be 200.
Sir, may I ask one question? Sir,
Yes,
is it
madam.
necessary to convert long-acting insulin to plain insulin or before surgery for elective surgeries?
Madam, intraoperatively or in DKA or in ICU, the insulin that we are using in our drips and infusion pump is Atrapid.
Yeah.
Atrapid is a regular insulin which has got a half-life of 5 hours. The analog insulins, which are just like they are brothers of Atrapid insulin, they have half-life of 3 to 4 hours. That means they are short-acting. But we should take into the consideration that patient has already taken a long-acting insulin. We have to assume that, because these people, they are on premixes, like Eglucin mix 50 or Novomix 50/50. They are on those drugs. So we have to also know at what time he has taken the last dose. Okay. And what type of insulin he is using. If they are using Novomix or if they are using human insulin, 50/50, then a regular insulin will have a half-life of around 5 to 6 hours. But the other long-acting premixes like Rhizodec, I told you, It has got a half-life of more than 24 hours. So in that situation, you will not need anything in the OT.
Okay. So the type of insulin will decide.
Yes, yes, it is very much important.
Sir, what is a Velor regime?
What is?
What is a Velor regime? Velor?
What type of regimen, for what purpose it is used, madam? I am not aware of this. What is Vellore regime? For
Yeah.
what?
For post-operative management of diabetes. Is it
No,
the
no.
same as what you said?
Madam, my guidelines, see, madam, are you talking about CMC Vellore regime?
Yeah.
Madam, no. My lecture today, my today's topic, I have used guidelines. Vellore regime is not, madam, used anyways nowadays, because that was the previous regime. It was a titration dose of insulin they used to do. But the titrations that I have told are from the journals. These are from the Research Society from Study of Diabetes in India and from British Journal of Anesthesiology.
Okay. Okay.
So Vellore regime is not used, madam. It was very age-old.
Age-old regime. Okay. Thank you, sir. You nicely covered the diabetes, ketoacidosis, as well as the management in the emergency surgeries, post-operative management of DM, as well as the diabetes GDM. Very nice to have you with us for the tight control of diabetes in either of situation. So thank you, sir, very much, sir.
Thank you so much.
Yeah.
Thanks a lot.
Thank you, sir.
Thank you.
Moving on to our next speaker, Dr. Amit Dixit. May I request Dr. Rajesh Deshmukh sir to please
I'm stopping.
stop
I'm
sharing?
stopping.
Yeah,
I'm stopping.
thank you. Is moving on to our next speaker, Dr. Amit Dixit. He's a consultant anesthetist in Ruby Hall Clinic, Pune. His present affiliations are he's a course lead for regional anesthesia fellowship programs of Ruby Hall Clinic, both MUHS and Aura Regional Anesthesia Fellowships. He's a member of board of studies for fellowships and research in Aura India. He's a peer reviewer of Indian Journal of Anesthesia. He's a PICEU Foundation team affiliation in organizing various workshops on POCUS, basic fate, advanced fate, and regional anesthesia. His major achievements are his articles, which are published in the index journals. He's also contributed to chapters in Regional Anesthesia Practical Handbook, Blockmate. Today, sir is going to talk to us about the diabetic foot surgery along with peripheral nerve blocks of lower limb. Over to you, sir.
Yeah. Thank you indeed, Dr. Aditi. Thank you for that kind introduction. I am really grateful to Shobha Vatkar madam for inviting me and giving me this opportunity to speak on such a interesting topic. I am also grateful to ISA Pimpri Chinchwad branch, and ISA Maharashtra. Uh, I know many of the familiar faces, including Dr. Maya Bhalerao madam and all, a very vibrant ISA team, and I'm really glad to be part of this excellent gathering today. I'll start my presentation when Vatkar madam told me we want to discuss a little bit about diabetic foot. And I'm very well aware that diabetic foot surgery is integral part of our anesthesia management, whether it is corporate setup, freelancing, government, medical college, whether you are working even in the remotest area. So this is a challenge we face every day. And therefore, can we do something with regional anesthesia and blocks? Can we manage these patients? So this is the question which I'll try to answer. And we want to be safe and we want to protect our patient, and we do not wish to get into any trouble. So I'll give you some guidelines from the literature. Also, I'll share some of my experiences, and it is up to you how to navigate through all these patients. Each patient is different, and every patient we have to respect that way. So greetings to you all from Ruby Hall Clinic. It's a 750 bedded multi-speciality hospital. We have right now three fellowship seats. Two are of MUHS, one is of AORA. We have a wonderful team of regional anesthesia faculties. We have 5 dedicated ultrasound machines with our department. We not only train our students into regional anesthesia, but also into point of care ultrasound. And whole of my department is trained in basic echocardiography as well. When we are dealing with diabetes, as we had a very wonderful lecture from Dr. Rajesh sir, and he described all critically ill patients. So it's now the way forward where we have to manage these little challenging cases, and anesthesia also has to grow in that respect. So my acknowledgements, I have utilized some of the diagrams from Nysora, and those reverse sonoanatomy diagrams are really very simple and easy to follow. I also acknowledge Dr. Madan Narayanan. He is a good friend of mine, a well-known faculty from EDRA. We are writing a book on EDRA Part 2 preparation, and I have used some of his slides, which has described about sciatic nerve. I am grateful to him. My acknowledgements also to my department. Every time department has supported me with all my conferences and workshop, and all the fellows who are very up and doing with creation of good videos and photos. I'll be sharing some of them today as well. I am a Ganga alumni, and I learned from Dr. Bala Venkat, and with AORA we have progressed to a very different level, and we are encouraging regional anesthesia across the nation. I have few photos and videos of my volunteers and patient, and I am really grateful to my surgeons. I'll be sharing, few stories where all those complications we have managed as a team. So, with this introduction, I would like to start with some of the literature review, and of course, I'll be sharing tips and tricks how to perform these blocks. So, those of us who are interested in managing diabetes and regional anesthesia. This is a very wonderful article in 2021 Anesthesia, and it is a review article, and it has highlighted mainly about the advantages and disadvantages. So in general, I'm just going to share a few of the important points how diabetes can affect, and these are all with good evidence. So avoidance of airway is one of the advantage where we can get away with a regional anesthesia technique, and most of them have difficult intubation. Everyone, it's during our PG days, those Atlanta occipital and all those prayer signs, everyone is very well aware. Avoidance of aspiration risk, we do perform gastric ultrasound as well, but delayed gastric emptying is a very important challenge with diabetic patients. And if we do it under regional anesthesia, it reduces the need for longer duration of NBM. So if the diet is started very early, early enteral feeding, then probably the risk of hospital acquired issues, like if we keep the patient fasting for longer duration after surgery, then they may land up with either hypoglycemia or hyperglycemia, because they stop having food, they stop having their own medications. They may land up with diabetic ketoacidosis, there can be medication error, there may be need for intravenous insulin. So it is good that we should make them eat and have their own medicine as early as possible. And I think this is very much possible with use of regional techniques. Now, reduced reliance on insulin infusion, as you must have seen all those regimens which Dr. Rajesh has wonderfully explained. It is difficult sometimes, errors can happen with those infusions. So, lesser the stay in the hospital, lesser the stay in the ICU, hospital acquired hypoglycemia, hyperglycemia, hospital acquired diabetic ketoacidosis. This is a term nowadays people use. Fluid and electrolyte imbalances can also happen, and confinement to bed is another challenge. So these all can be avoided. Mobilization is very important, and especially when there is a risk of diabetic foot ulcers and hospital acquired sacropenia. So they also call it as a pyjama paralysis syndrome or glow and stalking type of anesthesia. So we have to titrate our medications in such a way that they are up and doing, they start mobilizing. prehabilitation, rehabilitation, all these fast tracking of this patient is absolutely essential. Now, promotion of drinking, eating, and mobilization. There are many daring discourse in many editorials, and diabetes is not at all different chapter. It is absolutely essential that these patients should have a good amount of fluids. They should eat early, start their own medication, and they should be mobilized. So all this is essential. Now, attenuation of stress response, this has already been highlighted, and because it reduces the corticosteroid and catecholamine release and reduction in glucose excursion. So when we give any block or any neuroaxial technique, it has a very strong impact on reduction in catecholamine level, and it also reduces insulin resistance. Opioid sparing is another impactful advantage with regional technique, where it is reducing nausea, vomiting because of excess use of. So if someone has not received block, people tend to use opioid patches. They may use 4-2-Phenargon at night time. Sometimes some may end up using IV PCAs, morphine and fentanyl PCAs. So ventilatory impairment, persistent postoperative opioid use, dependency, all those urinary retention, pruritus, all that can be avoided. So how regional anesthetic is helping in shorter length of stay? So definitely with hospitalization, as we all know, we do not wish to continue hospitalization for these patients. So following ERAS protocol in a better way, and it helps a patient to start with normal food habit, and they start their own medication. Therefore, they avoid, and we can prevent the risk of hospital acquired hypoglycemia and diabetic ketoacidosis. Now, I'm just coming to very important discussion, which many of us are probably interested as what are the disadvantages of regional anesthesia. And I think at some point of time we have burnt our fingers and we have learned it a little hard way. And I know now there is good evidence also coming up. So I'm just going to share first and the foremost factor, which many of us may not be knowing, that the stimulation threshold for a brachial plexus found an average stimulation threshold of above 1 milliampere in diabetic as compared to healthy controls. So we always talk about zero point 0.5 milliamp current, zero point 0.5 milliamp current, and we keep on needling and we tend to maneuver the needle within the nerve because we want that twitch to happen at 0.5 milliamp current. But that is not possible in patients having long-standing diabetes. Long-standing diabetes may have threshold even gone higher up to not only to 1 milliamp but up to 3 milliampere current. So we may not get any twitch at higher currents also, and therefore doing needling is even disastrous. It can lead to damage to the nerve there. Second important effect is neurotoxicity and double crush syndrome. Double crush syndrome is a patient is already having insult to the nerve because of diabetic neuropathy, and now we are additionally creating one more damage by either with help of our needle or by injecting local anesthetic. All local anesthetics are potentially neurotoxic. All when so it leads to double crush syndrome. So diabetic neuropathy, we have to be very careful, and we have to use needles, not the hypodermic needle, but those which are described as per standard of care, and those blunt tip needles. We have to follow conservative needling. As far as possible, we have to move to ultrasound, because then we will not enter within the neural substance. And this is one of the recommendation in recent articles, that use of ultrasound is better, because we tend to do conservative needling and try to achieve uh, local anesthetic donut all around the nerve. And we should be avoiding vasoconstrictive agents and adjuvants in peripheral nerve blocks in patients with long-standing diabetes. Why? Because the sensitivity and prolonged block. So it has been noted that all diabetic patients have very high success rate. You just put a needle and deposit local anesthetic. Nerves anyways are having, all those microangiopathy, neuropathy. They will pick up very fast, and the success rate is very high, and blocks will last long. Detection of nerve injury is also even delayed in patients after spinal and epidural anesthesia because of pre-existing diabetic neuropathy. Patient may think that, oh, this numbness was already initially there, what to do. They will not suspect also. So suddenly you will realize that surgeon telling you or patient telling after maybe week that I am feeling numbness, still the numbness is continuing in my foot or something. So that's a disaster. So third thing is decreased need of adjuvants to LA mixture, because all these blocks do last quite for a long time. Now, what is the mechanism? The mechanism, it is by pharmacodynamic and a pharmacokinetic perspective is there. So what is the pharmacodynamic perspective? There is decreased inhibitory concentration of LA required to block global sodium currents in dorsal root ganglion neuron from a diabetic neuropathy. This is all noted and observed. Also, the pharmacokinetic perspective is the vascular supply and the perfusion of a diabetic neuropathic nerve is reduced, and this leads to prolonged duration of action. So again, already these are, there is a microangiopathy and perfusion itself is reduced to the nerve, and we add local anesthetic, it has a prolonged action. Infection is known. This was original article by Xavier Capdevila. He suggested use of, if you are planning to put a catheter, probably do subcutaneous tunneling. Uh, do not keep catheter more than 48 hours. Have good control of sugars. Pre-existing diabetes is can increase risk of bacterial catheter colonization. Groin and axillary catheters are prone to infection. There is also evidence of increased epidural hematoma and abscess formation in diabetic patient. So we have to be careful. Do not extend your epidural or perineural catheters for no reason. We should remove it as early as possible. Try to follow ERAS protocol. Medico-legal also is a challenge, and there is a increased risk. So we have to outweigh risk benefit and make a decision about. So whenever we are doing all these high risk patients who have very low EF and they want to do these, say, hip surgery or amputation surgeries, and they want to do it under block, we have to explain them that there can be delayed action of the numbness may remain with the nerve, and patient may have prolonged action of block for even 36 hours. So we explain them not only to the patient, to the relatives, but also to the surgeon. And there is a always we have to be very very careful what surgeons are doing, what steps they are following, whether they are handling the nerves, all those tight braces, lithotomy position, padding, nerve injury protection protocols we have to follow. Detailed documentation of discussion procedures and precautions should be mentioned. Use of USG is always good idea, because then we do not actually end up entering the neuronal tissue. If nerve is getting swollen up, probably you can take a snapshot on the ultrasound and keep that image stored and follow that patient. Usually, most of these patients do well, but they do take time for recovery. Most of the patients should recover by the end of 6 weeks. Some may extend up to 2 to 3 months. So I'll give you some of the tips and tricks in the end. Now let us, with this preamble of advantages and disadvantages, let us see some of the common blocks which are, it's a sort of a good revision for all of you when we are doing any lower limb block. So when we talk about any block, we have to know osteotome, myotome, dermatome. And the most important nerve when we are talking about diabetic foot, it is all from the sacral plexus and the sciatic nerve. So sacral plexus has various branches. One is the important is the sciatic nerve. Then we also have a posterior cutaneous branch. See how it is getting formed. Then we have upper nerves which are like superior gluteal nerve, inferior gluteal nerve, nerve to quadratus femoris. All these nerves are also there. So patient may come up for foot debridement, below knee amputation, above knee amputation. Uh, so I'm just letting you know the important course of sciatic nerve. When it comes out of the sacral foramen, it just comes, this is from the posterior side and it is coming below the piriformis muscle. Then it lies over superior and inferior gemella and is in the center is the tendon of obturator internus. Then it travels lower down between the ischial tuberosity and the greater trochanter, and then it is over the quadratus femoris, and below it then travels between the adductor compartment and bicep femoris muscle. Still lower down, it divides at the apex of the popliteal triangle into tibial and a common peroneal nerve. So we need to know this course, and the nerve can be blocked anywhere. Why we are so much interested in knowing the nerve? Because 99% the important nerve, which the take home message here is, all the surgeries below knee are predominantly supplied by sciatic nerve. Now, where is the femoral component? It may be little bit on the medial side, for which either we can do a femoral block or we can do a adductor canal block, or sometimes just a local infiltration near the all this where we call it as a near the saphenous vein where the nerve traverses. So I'll show you all those blocks as well. So when it comes to foot, we need to know that it is predominantly sciatic nerve, and all these medial and lateral plantar nerves, the sural nerves. Only this medial side, little bit is controversial, and some of the authors mention that below medial malleolus there is hardly any representation of saphenous nerve, which is a branch of femoral. So foot is predominantly, it is sciatic nerve. The sciatic nerve distribution ends more or less near the medial malleolus. Sometimes near some twigs may go up to the arch of foot. So what are the blocks? We can block parasacral sciatic, transgluteal sciatic, infragluteal sciatic, popliteal sciatic. Most of us probably would go for a popliteal sciatic. Sacral plexus block. Why we want to know sacral plexus? Because I'm just letting you know, sometimes after doing a very good popliteal block or with a femoral block, the patient is still wincing in pain, probably because you can see how the sciatic nerve can have anatomical variations. So this is the sciatic nerve in relation with piriformis muscle, and it is dividing into common peroneal and tibial nerve right up to here, where it is just coming out of the foramen. And see, this division has happened. So probably we have just blocked only one branch, maybe. So these divisions can cause a lot of anatomical variation. So sometimes some patients may complain of pain. So this was Thomas Benston's very famous approach on parasacral parallel shift, and here the nerve is blocked at the level when it comes out of the sacral foramen, and uh, so here also the superior gluteal nerve, the inferior gluteal nerve, all also the twigs are also being blocked. So you can see this is a very commonly done block, and I must tell you, for all these foot surgeries, sometimes the patients are very tricky. We do not able to identify the sciatic nerve lower down, so we sometimes tend to move more proximally. And here, by just placing the probe, we see this straight line of the iliac bone, and it just breaks into uh, two parts, and we see a hyperechoic structure which is the sacral plexus. So if we look at the sonoanatomy, sacrum on one side, ischium on one side, and there is a piriformis, and just lower down is the sacral plexus which is emerging. And either an in plane or out of plane technique, a single shot, sure shot block is a very good and easy approach at times, and it will take care of those anatomical variations, and patient will have definitely a very good anesthetic block as required. Transgluteal is another easy block, where we use a curvilinear probe. We just place the probe over the greater trochanter and just drop it down in the direction of ischial tuberosity. So technically speaking, it is little at a higher level where we tend to see the superior gamellae just below the nerve. And the PNS approach is the Raj approach, where we ask the patient to lift the leg, and then we identify the ischial tuberosity, we identify the greater trochanter, and we draw this line between. So this is the greater trochanter. So medial border of greater trochanter and the lateral border of ischial tuberosity, we just draw the line, identify the midpoint, and we can drop a perpendicular here, and up to 6 centimeter anywhere we can draw, put the nerve, and nerve is very superficial, even up to 5 centimeter we can elicit a good response. So this was the Raj technique where we have utilized the PNS. You need a good assistance to just lift the leg, and we can get a twitch there. So so this is how we elicit, and it's a very easy technique. The similar one on the sono anatomy is the ischial tuberosity, the greater trochanter, and in between is the sciatic nerve. If we look at the reverse sono anatomy, we have a gluteus maxima, the sciatic nerve. And so always aspirate, inject very slowly, use the PNS needle, and utilize around 20 ml of local anesthetic. It does require good amount of soakage time. We have to wait. We use dual mode, and we perform this block. So it can be used for ankle and foot surgeries, below knee amputations, involving the posterior compartment. Now, infragluteal sciatic is like we are coming little lower down, where the gluteus maximus has ended, and it is exactly between the greater trochanter and ischial tuberosity. So as I was talking about the Raj technique, where we drop a perpendicular up to 6 centimeter and anywhere in that line. So this is that line where you will see the course of nerve, which is almost straight, and it is much more superficial. So in an infragluteal area, nerve is very superficial, just and over the quadratus femoris. So it is coming over the quadratus femoris now. This is the quadratus femoris, and it is coming over there. And you can deposit the local anesthetic. So it is appearing as if it is in the hammock. So very easy to identify the femoral cortex, the ischial tuberosity, and it is nerve is nicely seen between over the quadratus femoris. It is seen in a triangular shape in here in this area. If we scan in the thigh area, it tends to be oval in shape. So there is something called as subtrochanteric or Gardini's approach, because some of the patients we identify that they are in supine position. So we identify the greater trochanter, and from the greater trochanter, we just drop for around 2 centimeter downwards and 4 centimeter, in the caudal direction. And there we pass a 10 centimeter needle. We tend to hit the femur bone, and just walk below that, and there we really can help with the sciatic nerve. So I'll just show you. We have passed the needle very well, and we tend to adjust the stimulation, and sometimes in these patients we get to stimulate the nerves at a little higher current, and you can see the twitch coming up in this area. As we are talking about all the proximal sciatic branches, either a sacral plexus or in that area, we can either get a tibial response or a common peroneal response depending on where we are hitting the nerve. All right. So coming to popliteal sciatic, I'll just show you both with PNS as well as with ultrasound. And here the nerve we suppose that it is believed that it divides into two at the apex of the triangle. But as I have shown you the anatomical variation, it can divide it into two branches right from where the sacral, where the sacral plexus is. And the classical response is the tibial nerve is the plantar flexion and the inversion, whereas common peroneal is dorsiflexion and eversion, how we see. And we have to look at more for a tibial response for the surgery. And this is how we do it. We do it in the prone position, and prone position is very ideal way. And we just draw a line at the popliteal crease. Then on the medial side is the semimembranosus, semitendinosus. On the lateral side is the bicep femoris. That's the popliteal triangle. And just we drop a perpendicular from the center, and almost 7 centimeters we mark that point, and 1 centimeter lateral to that. Or else we can divide this area into upper two-third and lower, sorry, the upper one-third and lower two-third. And you can see that point. So I'll show you one more time how we have drawn. So this is the triangle. This is the triangle. So one, two, three, three equal halves. This is the upper one-third and this is the lower two-thirds. So this is the point which I am selecting. And from this point, 1 centimeter lateral, 1 centimeter lateral, here we have to infiltrate, give local infiltration, and then we can just go bang straight. Now this is prone position. And how we have positioned the patient, we have positioned the patient, the foot should be a little bit, see the point where the needle has gone, and the foot is away, so that we can see the movement here very well. So you can put the foot outside the trolley or that area, so that you can see the movement very well, and you can appreciate the twitch also. All right. So this is a common thing. Another approach with PNS is the Vlokas supine one. And here at the upper border of patella, we just see this groove. So this is the groove between vastus lateralis and bicep femoris. And here we tend to put the needle almost at 7 centimeter above from this crease. And this is the known of Loka's approach. And with PNS, we have already shown you, it could be either so that is with PNS, but with ultrasound, when we place the probe either in plane or out of plane needling, we can put it and we trace the nerve all along. So what we see here is a very good artery, the popliteal artery, the popliteal vein. We have bicep femoris on one side. We have semimembranosus on the medial side. And here, very nicely, the nerve is in the paraneural sheath. And this is Vloka's paraneural sheath, as we know. And there is a septum also. Nowadays, people have found it out. It is called as a Compton curvilinear septum. And this is the how it is being divided. Previously, the school of thought was to, just bathe, pierce the paraneural sheath and deposit the drug. But now the recent school of thought is try and isolate each and every nerve and try and achieve good donut around each component. So trace it little more careful and try to deposit the local anesthetic there. So this is sort of a conservative needling, and don't go too much inside, otherwise it can be a subepidural injection. So here you will see the popliteal artery, the popliteal vein, the semimembranosus, semitendinosus on the medial side, the bicep femoris on the lateral side, and the two components of the nerve, and we address it separately. We deposit the local anesthetic. The word of caution, I think we in our department in last 10 years we had almost 6 or 7 reported cases that after giving a popliteal nerve block, there was foot drop. And this we have therefore we have devised a strategy that all these diabetic patients with lot of pre-existing neuropathy, so we have to follow some of the important protocol. One thing, do not add adjuvants, Do not probably consider a lot of vasoconstrictors. Secondly, go less on volume. Thirdly, assess the patient pre-op very well. Sometimes these patients are in pain, and therefore whether they have pre-existing foot drop or not is not being assessed. So we have to assess, make sure that there is no sciatic nerve injury before we perform any block. Thirdly, be sure about what are the tight braces they are putting, whether lithotomy, how much was the duration of surgery, what hardware they have done, whether the fracture was a too much of a complicated fracture, or sometimes all these amputations also took a lot of time, lot of blood loss, and what was the HbA1c. As Dr. Rajesh also have mentioned, HbA1c more than 10, already they have pre-existing nerve injury. Over and above, it will be very challenging. We prophylactically explain the relatives that the block will be longer lasting, more than 36 hours, and we follow these patients very closely. We don't put needle too much near the nerve. We try to achieve the donut. Now, as far as concentration, most of the time 0.5 is a percentage ropivacaine or bupivacaine is not required. For achieving surgical anesthesia, 0.276 is described in literature. Almost 0.276 percentage of ropivacaine and bupivacaine can cause surgical anesthesia. So we can limit concentration to up to zero point 0.3 without adding any adrenaline to it. No need for any even DEXA. Already these blocks are long lasting. Secondly, we also have to limit volume, and we have to follow these patients very try to avoid hypodermic needle in this area. So we have to follow all the precautions so as to prevent nerve injury or any untoward evidence. And in spite of that, it may happen in some patients, because this has happened to our patients with HbA1c of 12 or something. So we have to counsel the patient the risk benefit about this block, why we are doing surgery under this block. And because probably EF is 10%, 15%, and everybody is saying avoid intubation, avoid spinal. So we have to explain that this is the best possible way. So all these counseling, all these follow up, we have to sensitize our surgeon. We have to follow these patients up, and continuous reassurances. Maybe by the time they go home, they will have good functioning limb. But this is always a bit of a challenge. So unless your surgeons are aware, unless your patients are aware that this is a possible side effect of this block with this type of long standing diabetes, then we have to handle this. And even after spinal also it may happen. It may happen after epidural also. So a close follow up of all interventions is necessary. Now, I'm not going into greater details of how to manage nerve injury or something, but if there is any foot drop or something with spinal and epidural, usually within first 8 hours, CT or MRI to rule out hematoma, and later we have to follow. Most of the time, it is wait and watch for 2 to 3 weeks. Then there is role of nerve conduction studies, and later neurosurgical opinion after say 3 months or so. So this is a really tricky area. We do not wish to sell our block here. Surgeon and patient will have to purchase it. So everything is with some or other risk. So we are not selling any block here, because after doing lot many regional anesthetic block, we have realized that it can cause complication. So unless really everybody wants that patients to be done under block, because everybody is convinced that it is a beneficial block, then only we should get into this patients, all these with high risk diabetes patients. It is quite challenging to manage any complication in these patients. All right, hopefully I have given you some tips to handle it. I am aware that we do these blocks on a regular basis. Try not to get, you may not get any twitch at zero point 0.5 milliampere. Do not put too much effort in doing that. It may cause nerve injury. All right, so that was a word of caution for popliteal sciatic, though it is the most commonly done block, but it is a most fearful block in a way, I would say, in these group of patients. And foot drop is a very annoying and it raises suspicion on the overall management. Surgeon thinks that it is because of the anesthetist, or anesthetist thinks because of it has become because of surgeon. Patients also thinks that they are not being managed. So we need a very excellent team effort here, and we even should share articles to our surgeons as what is the ideal sugar, what is microangiopathy, what is neuropathy, and we should be very thorough with our assessment as well pre-op, so that there is no and very good documentation as well. So this is all about popliteal sciatic block. We need to identify the nerve. Do not put needle too much close. Do conservative needling. Now, this is another approach, as I have described the Bloca's approach. Then another approach is a CAPS block done by my friend, Dr. Tuhin from Ganga Hospital. And here it is, this block is a popliteal block with ultrasound in supine position. And here the nerve is going, where we have used a PNS in the same way, just between the vastus lateralis and the bicep femoris. So we can see the needle going through bicep femoris, and it is approaching the sciatic nerve. So femoral nerve, I am not going to highlight much, but some aspect, the medial side, just below the knee, is supplied by saphenous, which is a uh, branch of femoral. And femoral nerve block with PNS, if we have to identify the femoral crease, I usually identify put the thumb and over the artery, and I tend to hold the lateral edge of the artery at the level of femoral crease. And just from there, 1 to 1.5 centimeter lateral and caudad, we have to identify that point. So we have to guide with left hand thumb. We just have to knock that uh, lock that lateral edge of the femoral artery. This method was popularized and taught to me by Dr. Bala Venkat. And Bala Venkat sir showed always in even in obese patient very good quadriceps twitch. So it is a relatively straightforward block. And femoral is relatively okay block, but a word of caution always with a popliteal which I have already highlighted. Now, femoral can be done very well with a ultrasound, and we see very nicely honeycombing of femoral nerve, and we see the fascia iliaca and the psoas there. So you can see the layer of fascia iliaca, how it opens up and it encroaches and covers the femoral nerve, and we have to pierce fascia lata, fascia iliaca, and try to deposit the local anesthetic. I usually would approach the nerve at the lateral edge. Do not tend to put needle inside the nerve. Just try to open up that area and try to achieve a good donut all around the nerve. So it can be used for all the below knee surgeries also. Sometimes the also for the hip fractures, and to make that patient sit. So it's a very commonly used skill set for adductor canal block has come up in a big way because we are covering the saphenous aspect for all those below knee amputations, foot debridement, where we just want to cover that medial aspect. So why not do a adductor canal block? And it can be done at a mid thigh level. Now, where we should deposit the local anesthetic is when the femoral artery is almost at 6 o'clock position to the sartorius, and here is the saphenous nerve, and we identify the saphenous nerve, and just below the sartorius at 6 o'clock position to the sartorius, when we have the femoral artery, we have to deposit the drug, and very well it can be done with the help of a ultrasound. Now, in my personal opinion, sometimes we can get away with a good saphenous nerve block for all these foot debridements and amputations. But in some patients, there are many anatomical variations. So, when the patient is obese or patient has very low threshold of pain, then probably I have gone in those group of patient for a straightforward femoral nerve block instead of an adductor canal block. So of course the choice depends on how is your setup, how is the given patient, how is your surgeon, whether they will cooperate for that medial side where the incision will be predominantly. All these factors you have to take into account. More you go proximal as a sciatic and a femoral area, you will cover most of the anatomical variation and it will be a sure shot block. But as we go more proximally, then it will cause a dense block and more motor paralysis as well. So we have to outweigh risk benefit and early mobilization protocol and what should be the concentration and whether we have any options. Now, this adductor canal block has also been used for ankle and foot surgeries. Ankle block is a very, very well-known block, and most of us during our PG days have created a circular ring of ankle block where all those five nerves are blocked, and we can see all the deep peroneal, the superficial peroneal, the tibial, all the sural and the saphenous nerves are blocked. My suggestion would be probably if we can, because I am also doing these scalp blocks or something like ankle block where we end up giving 5 or 7 injections. If the patient, if we can manage with maybe 3 or 4 cc's of propofol, then probably they will not remember anything of what the needling and all these bad memories. Because some of our patients have said that, in the name of ankle block, you have pricked me 9 times. They will count all this. So you have to be careful while performing this block with landmark technique, and because it is quite painful and barbaric. uh, so we can give titrated propofol just for time being. It's a very good reversible sedation. Of course we have to see how is the patient, because all these midazolam, fentanyl, if we overdo it, or dexamethasone, it will have longer effect on all these octageriatric, nanogeriatric patient. Sometimes a very light, short duration sedation is required just for block performance. Even in some, very VIP patients also, where they are looking at your pricks, you can provide and make them, provide a better experience. Now, I have placed catheters also for sciatic nerves, and it's a very good idea to put continuous catheters for sciatic nerve, because then we do not have to go very high on concentration, because we do not want a long lasting block. We can just go low on concentration, low on volume, and then place a catheter and start an infusion, so that at the end of surgery, the first common question after doing so many medical patients, those who are doctors and those who have undergone Achilles tendon repair or any diabetic foot surgery, the first question they will not ask about pain, but they will ask you that when I will be able to move my feet, why this numbness is so much there. So they want full good excellent surgical anesthesia, and the second challenge, immediately once the surgery is done, they want a pain free leg and which is also moving without any motor paralysis. So this wonderful technique we can utilize in these group of patients is definitely use of a low concentration drug followed by a continuous infusion, and we can just remove it at the end of 48 hours. All below knee amputation surgeries, I think, depending on the surgical incision, either it is below knee or above knee, we have to place continuous catheter, either a femoral or a sciatic. It is excellent idea. Or we can repeat the block next day, because if we do not do it, probably it can lead to phantom limb pain. At least a good block is necessary. Along with that, multimodal analgesia, maybe subanesthetic dose of ketamine, IV lignocaine, or gabapentin. All this has been found to reduce pain chronicization. So this is another important area and challenge. So I'm just highlighting the nerves, the tibial nerve block at ankle. We can use PNS because there is a motor supply to this nerve, and I have even shown the twitch here. If we put a nerve and attach PNS in this area, we will get a twitch, and this is the tibial nerve, and we will have, you can see the flexor digitorum longus on one side, the posterior tibial artery. It's very easy block because we can feel the pulsating artery down there, and we can identify the honeycombing of the tibial nerve, and we can deposit the drug. On other side is the Achilles tendon. Saphenous nerve block is little on the medial, just above the medial malleolus, and the important aspect is the saphenous vein. By the side is the saphenous nerve. As we see all these nerves very clearly and distinctly, we do local anesthetic sparing, and we can get away with very less dosages of drug, and we can be precise with our needling as well. So here is the saphenous vein, and just by the side is the saphenous nerve. Now the deep peroneal, which most of us probably, we all tend to have that habit of palpating for the dorsalis pedis. Just try and do it more in the proximal area, and we try to identify. Even we can ask the patient to move his great toe so that we can identify the tendon of external hallucis longus, and just by the side there is a arterial pulsation, and in between that we have to know that there is a deep peroneal nerve, and a fan shape injection of maybe 3 to 5 ml is a good idea. So this is how we identify and deposit the drug just by the side of artery. Sural nerve is on the near the lateral malleolus and the Achilles tendon. Sometimes just a subcutaneous infiltration is enough, but you can see a short saphenous vein, and by the side is the sural nerve, and we can deposit the drug. Another area which is important is the superficial peroneal nerve block, and here it is on the lateral malleolar side, little higher up, where we identify here there is no vessel, unfortunately. The landmark with ultrasound is we have a peroneus brevis muscle and external digitorum longus, and in between you will see the honeycombing, and that's the superficial peroneal nerve. So we can deposit the drug around very well. It is seen like this. So before we close this session, two, 3 points which we have learned from our mentors, and stop before you block. So all the ultrasound machines we need to know, because these patients have bilateral issues, and both the limbs may have some dressings. So you should be very, very sure which nerve, which block, where we are blocking, which side is the surgery. Chlorhexidine with alcohol base is the anesthetic solution of choice, but sequential drop of uridine, iodine with spirit in WHS is helpful. So there is a mnemonic called as push, pull, pinch, pinch for upper limb. Now similar is the mnemonic for push, pull, pinch, punt for lower limb. So here push is for the tibial component, push against resistance. So patient is asked to push his foot against resistance, and that is for the tibial sciatic component. Pull is for the obturator nerve. Yeah, I think.
Can you mute the
Yeah, the host can do it, maybe.
Yeah.
Yeah, thank you. So the pull is for the adductor group of muscles. If we have done an obturator nerve block, just asking the patient to adduct in the midline. Pinch is for the lateral femoral cutaneous, and punt is like how we elicit the patellar uh, tap or the deep tendon reflex. So this is how we just put and ask the patient to extend at knee. So unable to extend at knee is quadricep weakness, and this is the predominant effect of femoral nerve. So regional anesthesia documentation is absolutely essential. 22 gauge, whatever, stimuplex needle, 10 centimeter, echogenic, what sort of ultrasound machine, in-plane technique, how much ml of drug, what was the anesthesia strategy, what were the procedural details, complication, immediate, if at all, and post-operative analgesia. So this is our RA documentation form, and this is now also part of AORA logbook. So our students fill this. So here you can see the demographic data. Then they have to mention what is the dermatome, myotome, osteotome, and the innervation. So then they have to describe the strategy, whether they are doing a central neuroaxial plus a peripheral, or it is only central neuroaxial. Then whatever is the sonoanatomy, they will have to draw the diagram with pencil or with a color pen. So this is another for lumbar plexus, and drawing of a lumbar plexus with ultrasound. And lower down is also the other relevant procedural data. If PNS is also being used, then what was the desired end motor response, at what current you got, then what was the probe used, how much was the needle, how much was the depth, what concentration, how many ml of drug, and was there any sparing, the nerves was assessed, so what was the sparing, were there any rescue blocks required. So then next page, this is two-page form, so they will have to put the areas for dermatomes covered after doing a block. So this was a patient after lumbar sacral, after the lumbar plexus block. So all the area which is getting covered, and then if there are any immediate complications, so immediate complications are the vascular complications. If it is for upper limb, then the pneumothorax, Horner; for spinal epidural, paresthesia. Then the last related complications, if there are any signs of any numbness, agitation, seizures, arrest, bradycardia, hypotension, and late, which is followed after 72 till 72 hours at least, if there is any persistent neurological symptom. Lower down, we have kept as they will be doing a good follow up on day 1, 2, 3, morning, evening, and so every 6 hourly. And what was the VAS score, static and dynamic? What were the rescue analgesics? What was the plan? And how much was the total duration of sensory and blockade? How much was the total duration of motor blockade? And how much was the total duration of analgesia? And what are the reflections as why the something has happened? So what was the cause, where there tried braces, or what was the approach, or what was the drug concentration, or any difficulty in assessment because of fracture, whatever. So every block will teach you something differently. Also, we have made a WhatsApp group for our department in which we enter each and every block, and therefore it is very easy to follow that patient, and also it encourages everyone to do more blocks and do more regional work. We are doing yearly audits, and that is how we got all the equipments in our department, also the regional anesthesia fellowship from MUHS and AORA. Audits will showcase your work, and it is more scientific way of addressing, so then we can ask for new machines also. So complications, we have I have tried highlighting that nerve injury, infection, delayed recovery is always a possibility in diabetic group of patients. Pressure necrosis and insensate foot because of continuous catheter technique or higher dosage of drug is a possibility. So we have to be very, very vigilant. Preoperative neurological evaluation is a must. We cannot give any sciatic or sacral plexus block unless we rule out that there is no foot drop in this patient. Otherwise, later it is only because of your technique. So all what they do with bipolar, which are the surgeries where nerve can get stretched, we need to know that aspect as well. So the take-home message is, of course, about drug dosages and technique is try to use low concentration. Surgical anesthesia can be very well achieved even with 2.276, so up to 0.3 percentage is good enough of ropivacaine, levobupivacaine, or bupivacaine. Use less of volume. LA mixture, we can avoid adrenaline and other adjuvants when it comes to sciatic and block. Avoid intraneuronal injections. So it is good idea that we do conservative needling, try to achieve donut, don't go within the substance of nerve. If there is any neuronal swelling, store those images and follow those patients meticulously. 95 to 99 percentage of the time nothing will happen, but you already know that some, accordingly you can counsel the patient. So if you are anticipating something, then reassuring the surgeon and the patient relative that for a delayed recovery becomes easy. Use all standard practice guidelines. Do not use squinky needles or hypodermic needles or those which do not have good evidence to support. We can get away with the situation most of the times, but it's a very very big if challenge. I was doing one workshop in Rajkot, and at that time, from a senior professor, she said, I am the head of the department at medical college here in Rajkot, and there are three cases where there were nerve injuries to the patient, and one has used all those techniques without taking proper precaution. Now it is up to me how what to report, and all those. So this is diabetic patients are a big area where medical legal issues can happen. So it's a teamwork, and you have to counsel surgeon, patient, discuss outweigh risk benefit, and then only. So we do not sell anything, they will have to buy, because it's really a challenging area in this group of patients. So regional anesthesia should not be considered as a very a very nominal thing, and we can get away with this patient with low money or low budget, something like that. It is not so. It can be very very tricky, and pre-procedural counseling, sometimes we can prophylactically say that block will extend up to 24 hours. In some patients it may be up to 36 hours. This works well for most of the patient. But if you say that block will wear after 12 hours, and if it is on 13th hour, you will get a call that, see, numbness is still there. So surgeon is calling, patients are calling. So you will have to tell them and explain them the real situation, and try to follow these patients very closely. So pre-operative evaluation about the neurological situation, the patient comorbidities, what is the HbA1c. In USA, they will not do any elective surgery if HbA1c is more than 7.5. But that is not the case in Indian scenario. Our patients do have higher, all these values, and therefore we have to counsel our patients very well. Risk of infection, risk of delayed wound healing, hematoma, all neurological issues, nerve stretching, longer duration of surgery, hypotension, electrolyte imbalance. So careful selection of anesthesia strategy. Block is not everything. Sometimes GA with local infiltration anesthesia will give you a peaceful good night's sleep, and I think nothing wrong about it, because we do not wish to see any complication with any of our patient. And multimodal analgesia works really well. Most of these patients have numb limbs, and we have to really assess it carefully. Post-operative monitoring for at least till the time of discharge. If that is not possible, at least for first 72 hours is absolutely crucial. Hopefully, I have sensitized you with various blocks in this area and the word of caution. So, thank you very much for patient listening. If you are interested, do join us for a very upcoming bright conference in Hyderabad this year on 22nd to 25th of August. We have many who's who in regional anesthesia, Vincent Chang, Manoj Karmakar, Hari Kalagara. We have regional anesthesia and focus workshop. So I welcome you all for this. Thank you very much, madam, for giving me this opportunity. Thank you.
Amit, I really thank you for the vast coverage of your topic. I thought it will be a few videos, but then when we listened to you, it really sounded that how much careful we should have been. And I really like your sentences. We don't have to sell. The surgeon has to buy it. Okay, that sentence really appealed me. Yeah. So this is the regional anesthesia, which is not so easy, not cost effective or economy, but it really needs a storming as well as long learning curve.
has to be there with excellent choice of the patient selection, and post-operative as well as the pre-operative monitoring. I really liked those charts which you showed, and those charts we have at Myanmar have fellowship regional, but I don't think so. We have those charts which needs to be followed, and
We will
excellent
provide them.
recording. Yeah, the recording actually saves you with a lot many complications if the things are documented and recorded. So
Yes.
we need to take care of that action and proper documentation, and soon we'll come to you and follow those records and documentation. Thank you so much. Thank you so
Yes,
much.
yes, thank you very
Few
much.
questions, sir, before you leave.
Yes.
Is coagulopathy contraindication for sciatic block?
Yeah. So that's a really interesting question. When we read about, say, I'll quote a standard textbook, which is Cousins and Bredenbow. So Cousins and Bredenbow, neurological, new regional anesthesia, we have a good edition. And so there are three gray areas in regional anesthesia. One of them is severe hypotension. Second is infection, and third is coagulation disorders. So all these areas, the concerned anesthesiologist discretion, we have to outweigh risk benefit, and then we have to plan for surgery. Of course, 2022 European Society guidelines have come up, which has divided superficial block and deep blocks. So all those patients who are on, say, ecosprin and clopidogrel, we can do superficial blocks, but when it comes to lumbar plexus, sacral plexus, these deep blocks should be definitely avoided in patients who are having coagulation issues. So it is always a gray area, and concerned anesthesiologist discretion, you will decide whether the block has to be done or not. Yes. Hopefully, I have answered
We
your.
also have one more question. We use 0.1 to 0.15 of hypobaric bupivacaine for unilateral selective spinal. In such cases for debridement and foot surgeries. What is your take on this?
This question is by Dr. Naresh Paliwal. He was there earlier.
Yes.
I think he has left now. So, sir, you can ask. I mean, you can answer that question.
Yeah, yeah. So I think Dr. Naresh Paliwal sir has himself a very good speaker and an orator, and he has been humble enough to ask this question to me. Of course, I would suggest that you just have to look at the pathophysiology of the disease process, and most of them have autonomic neuropathy, and they may have orthostatic hypotension, they may have glow and stalking type of anesthesia. So sometimes getting away with a unilateral spinal is a good idea, instead of venturing into a block which can last for a longer duration. So most of us probably would go for spinal with low concentration and low dosage, and it also depends on your own work experience and the category of patient. So when it comes to octa, nano, and all those geriatric group of patients, it depends upon the CSF volume. So how we choose local anesthetic is, um at the age of 140 years of age. Of course, we do not have anybody till 140 years of age, but at the age of 140 years, we really do not have any CSF left in the body. So whatever local anesthetic we do, it will be very, very, we have to go less on dose. So the dosage regime is, if we have a lower limb surgery, so if a patient is around 100 years or something, probably 0.8 ml is a very good idea for bilateral spinal. When it is 90, then probably 90 to 100, then 1.2, 80 to 90, 1.4, 70 to 80, 1.6 to 1.8, less than 70, probably somebody would use 1.8 to 2 ml. And for unilateral, you have to be very, very gentle. And they say that you have to turn patient on one side and give as slow as possible till you are absolutely bored that you cannot go even slower than this. That is how the speed should be. It is said that it is 0.3 ml per minute should be the speed, or even lower. Then you do not cause any turbulence, and then it doesn't become bilateral. So we have to be very, very gentle. And then again, the baricity issue you have to take into account, whether it is hypobaric, hyperbaric. And the age, the patient, also there is down regulation of receptors. So therefore we require, even the muscle mass is low. So for surgical anesthesia, again, the volume required also is less. So all these factors and your own personal experience in managing these patients. Suppose some patient may have craniotomy or something, then again it is a relative contraindication. They may end up in spinal shock with even 1 ml or 1.2 ml, something like that. So all those neurological assessment and everything, you have to assess and decide the exact dose of the patient. So I think we have to take into account all the factors. Thank you.
So, which block is preferred for below knee amputation?
Again, few factors. If otherwise, straightforward patient, probably because as I have showed you, the whole of dermatomal innervation is by sciatic nerve. So only the little aspect of medial part up to medial malleolus is by the saphenous component, which is a branch of femoral. So what we have to address is the sciatic nerve. So we can address sciatic nerve depending on the patient, whether we want to do it in supine position, lateral position, if it is possible. So, or how big is the incision, whether they are going above the knee, below knee. So popliteal block is the most commonly performed block for all these procedures, with or without femoral or adductor canal block. So sometimes just shin of tibia on the medial side, little local infiltration can provide some coverage to the saphenous aspect. We can place an ultrasound probe and identify the saphenous nerve just adjoining the saphenous vein there. So that also can be done. So if the surgery is predominantly on the lateral side, I think sciatic is just more than enough. And if we want to utilize it for post-op analgesia, then there is no need for saphenous or a femoral component. Only sciatic block is with either a 0.2% ropivacaine is enough.
Sir, somebody has asked whether they can use lignoadrenaline with ankle block for an ankle block.
Yes, so I think as in general, most of these are very superficial nerves, and our uh, what the general consensus is we want that faster onset of action and all that. So so long as um, I think most of us eventually use for when it comes to ankle block, but I would suggest they do not require very high quick or action. Most of them are partially numb, these diabetic foot patients. So you have to see why you want to use adrenalized solution. Most of us want a very quicker onset. For that we want to utilize it. Or secondly, when we are very close to nerve, nerve is very close to vessel, and we want to avoid vascular effect, then we want to add adrenaline, because it may cause go into vessel or something. So then we use, or we want to limit our action for a very short duration, so we want to add adrenaline. So I think, or the third reason could be because we want to use more drug. So instead of lignocaine, I can use more drug. So locks with adrenaline is higher toxic dose because systemic absorption is less. So these are some of the reasons. So as far as literature has said about diabetic patients, avoid adrenaline. Adrenaline can be used where there is high risk of systemic absorption, say intercostal nerve block, or those areas where vascularity is very high. So in order to avoid higher systemic absorption, lignocaine can be combined with adrenaline even in diabetic patients, in this group of patients. So
But
it's
we
purely,
avoid the end arteries, we avoid adrenaline, isn't it? Like an
yeah. So when mostly when somebody is doing an ankle block, they try to identify some landmark, but eventually, as I have mentioned, it is more of a barbaric, and people end up putting 7, 8 time pricks and eventually encircling whole of the area. So it's good idea to read anatomy, good idea to read the nerve supply and try and target only those nerves which are, so surgery is only say on the great toe, so no need to block sural and everything. So if we can be more methodical and scientific in this.
Yeah, they can be selective and can spare the solution, isn't it?
Correct, correct.
So how do you tackle tourniquet pain with ankle block? Tourniquet pain.
So again, there are good textbook references that if we want to avoid tourniquet pain, even we can do a popliteal sciatic block and put a tourniquet below knee. And it is mentioned that previously we have read that the concept is we cannot put tourniquet below knee because common peroneal may get damaged. But this is now a textbook statement that we can still put a tourniquet below knee and it can be applied safely for half an hour. So just one single popliteal sciatic injection will cover, avoid all those 5, 7 pricks, and it will cover the foot area and even plus minus saphenous, and we can put a tourniquet. And tourniquet pain is predominantly an ischemic pain. So if we have given a good sciatic block, it should suffice. And we do not wish to extend for more than half an hour. And it will not cause foot drop or any other untoward incident. And we have good supportive evidence to say that we can put it. So mostly these are the infected foot, diabetic foot and all those surgeries. So we do not wish to go into that area, and people don't actually put tourniquet down there on all these patients. They want that area to bleed and they want to see the granulation tissue and which is the healthy area. All right.
Thank you, Amit, for your practical pearls. It really, for you, it may be really exhaustive. They may be not long-lasting questions, but again, you satisfied everyone with your talk, and it's really an excellent talk. I must thank you because we never had a chance to arrange such a lecture with you. So I really thank from bottom of my heart. Thank you so much. Yeah.
Thank you. It was pleasure
I call
having.
upon Dr. Uma for the vote of thanks. Dr. Uma Deshmukh.
Today, I am really honored to propose this vote of thanks today to conclude such a wonderful webinar. It was really amazing. To begin with, I wish to thank Dr. Rajesh Deshmukh from Nagpur. His fluent words brought forth his command over the subject, and his perseverance as a physician was apparent and natural to the additional qualifications he has. He has such wonderful slides, making a very complicated subject appear very easy. Thank you, sir, for such a informative and very useful presentation. Next, I would like to thank Dr. Amit Dikshit from Pune. He gave a wonderful insight into the selection of type of anesthesia with very useful diagrams to learn from. Both the speakers today were extremely thorough and amazing. I'm falling short of words to describe them. I wish to thank our president, SAPC president, Dr. Shobha Vatkar, for her constant effort to bring forth helpful things for branch members. Today's webinar was just an example. I wish to thank Dr. Bhavesh, our silent, soft-spoken and sincere secretary, who is the pillar of SAPC always. Then I wish to thank SAMS office bearers, Dr. Balaji Asegaonkar, who is the president, and Dr. Rajesh Tagadpalle, who is the secretary, for their continuous and valuable support to all our SAPC activities. Then I wish to thank SAPC committee member Ganesh Kathar for the digital platform he provided, which was uninterrupted and clear digital platform, which made us which enabled us to enjoy all these amazing presentations. And all the members from here and away, wherever they came from, who logged in and stayed with us. And I'm sure all of us have a very good time and living in a diabetic capital of the world. we are definitely have got lots of pearls of wisdom today. Thank you everybody for being with us. Thank you, sir.
Thank you very much.
We must say long live ISA because Bajwa sir said we are the branch members of National ISA. So long live ISA.
Yes, thank you.
Okay, sir.
Long
What,
live ISA.
Thank you.
what you
Good.
want to say, sir? Anything else?
No, thank you. It was a really wonderful experience, very meticulously arranged. Thank you indeed for inviting me. Thank you.
Yeah. Sir, where will you get those record forms?
They are available also on AORA website, madam, in the download section. We have made it available to everyone. So you can visit the AORA website, the download section. Logbook page is available there.
Okay, okay.
Or else you can have it from me also, no problem. I'll send it on WhatsApp.
Yeah. Thank you, sir. Thank you so much. Yeah. With this, I conclude the session. I declare that the webinar is over. Thank you so much.
Thank you. Good night.
Good night.
हेलो मैडम मीटिंग एंड करते हैं
हो हो जरूर